Hello everyone, myself Dr. Madhusudan. I'm working as senior resident in the Department of Dermatology, Veneers and Leprosy in SSIMST Begur. Today we are speaking about the case that we have seen in our OPD, that is patient with the scaly lesions, and I'm gonna go through with this case for today. The patient, a 45-year-old male patient, came to the OPD. He was driver by occupation and he was resident of Nelmangla, present to the dermatological OPD. He came with the chief complaints of red raised scaly lesions all over the body since 8 months and itching over lesions since 2 weeks. The patient was apparently normal 8 months back when he started developing the small red raised lesions, scaly lesions over bilateral elbows and knees. But lesions gradually increased in size and number over a period of like 8 months, spreading to the lower back, bilateral forearms and legs. And patient had mild itching before, but since 2 weeks the itching has increased. The patient gives history of worsening of lesions during winter and relieved on taking some topical medication which was prescribed by a local doctor in some local hospital. And the patient gives history of appearance of new lesions over the site of trauma. And there was no history of any other aggravating or relieving factors, and no history of joint pain, no history of fever, no history of photosensitivity, no history of any oral or genital ulcers, and no history of drug intake prior to the onset of the lesions, and no history of discharge from the lesions. Patient was treated for the same complaints in a local hospital with which patient doesn't remember, and there was no history of similar complaints in the past, and no history of any TB, asthma or diabetic mellitus or hypertension. Coming to the drug history, there was no history, as I told, like there was no drug history of any drug intake prior to the appearance of the lesions, and no history of any other drug intake presently. And family history, no similar complaints in the family. Coming to the personal history, diet is mixed, appetite is good, sleep is sound and adequate, and the bowel and bladder habits are normal and regular. He is a known smoker, he's a regular smoker, and he consumes alcohol on a weekly basis. Coming to general physical examination, patient is well conscious, cooperative and well oriented to time place person. His vitals were stable and pallor, and the patient doesn't had any like pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. And other examinations like scalp was totally normal, oral mucosa was normal but had a stained teeth, and eyes were congestions were present, and palms and soles were normal. There were no lesions, otherwise palms and soles were not involved, and the genital mucosa was normal. Coming to the cutaneous examination, multiple well-defined erythematous plaques like covered with silvery white scales. As we can see here, like there are multiple lesions which are present over the lower back and over the extensor aspect of the legs and over the knee joints and over the elbow joint, as we can see here. The lesions were like quite scaly, like silvery white scales, as we can see, with the background of like erythematous background is seen. And calmness phenomenon was present as we like, and the Gratach test, which we did like a bedside examination where the auspicious sign came positive. Coming to nail examination, we saw like coarse irregular pits were present, and the oil drop sign was present, and the subungual hyperkeratosis was also seen. Coming to the systemic examination, as the patient doesn't like his cardiovascular system or respiratory system and per abdomen and CNS were totally normal. Coming to the clinical differential diagnosis of this case, we come to a conclusion based on the history and with the examination findings. Either we can consider like psoriasis or with respect to the disseminated eczema. And these things can be confirmed, like the diagnosis can be confirmed based on the investigations and other clinical findings. So coming to the investigations, we had done CBC, that is complete blood count, CRP, ASLO titer and FBS and lipid profile with LFT and serum creatinine. The patient had CRP elevated because of the inflammation, and leukocytosis was also seen. And the histopathological finding, that is the biopsy of the skin, which gave like findings like epidermal hyperplasia was seen coming from the top to bottom, that is like along with the parakeratosis with focal orthokeratosis, and the absence of the granular layer was seen, and elongated and clubbed retail ridges, suprapapillary epidermal thinning was present, and Munro's microabscess was seen, and mixed dermal infiltrates of lymphocytes and neutrophils was seen, and along with the dilated papillary vessels were also seen. So coming to the final diagnosis, like based on the history of red raised lesions over a period of chronicity, that's over a period of 8 months, along with the presence of itching and with Cobner's phenomenon present, and with respect to the clinical examination findings and the biopsy findings, we come to a conclusion that the patient has like psoriasis, like more suggestive of chronic plaque psoriasis. Presently, the patient is on treatment with the topical emollients, and along with that, systemic, where patient is on oral methotrexate. Along with that, the patient is taking narrowband UVB. Coming to the discussion part about the chronic plaque psoriasis or the psoriasis overall, it's a common chronic papillomatosis disorders. It does not only affect the skin but also involves skeletal system, liver, eyes, CVS, and other systems as well. So the disease severely affects the quality of life, and the genetics, environment, infections, trauma, stress triggers the disease actually. Coming to the pathophysiology of the psoriasis, basically the plaque psoriasis, it's an immune mediated inflammatory condition like characterized by the hyperproliferation of the epidermis on the abnormal differentiation of the basically the keratinocytes, driven by dysregulated interaction between the innate and the adaptive immune systems. The process begins with antigen presenting cells such as Langerhans cells activating T cells in the regional lymph nodes, and these T cells return to the skin where they secrete pro-inflammatory cytokines. So basically the more of like inflammatory cytokines will be released. So these centered around the interleukin 23 and 17 axis and the tumor necrosis factor pathways, particularly the TNF alpha pathway that promoting a chronic inflammatory response. This inflammation basically results in the recruitment of additional immune cells such as dendritic cells, neutrophils, and macrophages to the dermis and epidermis and amplifying the cycle. So the keratinocytes respond to these cytokines with rapid proliferation, causing epidermal thickening, that is the acanthosis part, parakeratosis, that is retention of the nuclei in the stratum corneum, and impaired differentiation. The accelerated turnover, that is like normally it used to take around like 28 to 30 days, but here in case of psoriasis, it will be around like 2 to 5 days or 2 to 3 days, 3 to 5 days, and decreased lipid secretion leads to the characteristic scaly plaques. So vascular changes including superficial blood vessel dilatation and neovascularization and contribute to these lesions appearance. And the chronicity of the plaque psoriasis is maintained by ongoing crosstalk between the immune cells and the keratinocytes, sustaining a vicious cycle of inflammation and skin remodeling. And persistent resident memory T cells explains the recurrence of the plaque at the same sites. Coming to the normal histopathology, in case of like psoriasis, in the early lesions, in the beginning of the lesions, normally there will be like vasodilatation, papillary dermal edema, and leukocyte infiltration, and these changes are followed by like compact hyperkeratosis, loss of granular layer, epidermal hyperplasia, and focal parakeratosis, where the dilated and tortuous papillary capillaries with mixed inflammatory infiltrates are prominent. And coming to the fully developed plaques or the later stages of the plaques, they demonstrate parakeratosis with focal orthokeratosis, near absence of the granular layer, and elongated and clubbed retail ridges, Munro's microabscess, and mixed dermal infiltrate of lymphocytes and neutrophils, dilated papillary vessels, and occasional necrotic keratinocytes. As we can see in this patient, we had almost like the fully developed plaques were demonstrated. The biopsy reports were similar to the fully developed evolved plaques. And normally the treatment plan, it usually takes like counseling, because most of the patients comes to the cure, but it's not curable, it can only be controlled. So the counseling plays a major role. And coming to the other general measures has to be taken, like topical agents and NBUB has to be promoted, and other systemic therapies can also be considered. As we can see, the topical treatment is the first line treatment for in case of like minor cases, like when the body surface area is less than 5% involvement, and the common agents which includes like topical corticosteroids can be used, vitamin D3 analogs, retinoids, coal tar, anthraline, and salicylic acid can be used. And the phototherapy is recommended for patients with inadequate response to the topical agents or with more widespread disease. So narrowband UVB is preferred for efficacy or safety, and broadband UVB and excimer laser, the eximers like 308 nanometer, are alternatives for the localized plaques. PUVA is effective but less favored due to its cumulative phototoxicity and the carcinogenic risk. So therefore, eye and skin protection as well as tracking of the cumulative doses are required. And coming to the systemic therapy, systemic non-biological therapy, once again we are dividing it into non-biologics and biological therapies. Systemic non-biological therapy is appropriate for moderate to severe disease where the body surface area involvement is more than 10%, the PASI score is more than 10. Rapid flares are present in patient or special sites like nails, scalp, palms, and soles, where the patient will be recalcitrant to the normal or the topical treatments. Methotrexate remains the cornerstone therapy, and it should be accompanied by folate supplementation because of its side effects, which should be considered, and with regular monitoring has to be done in case of methotrexate treatment. And along with the regular monitoring of complete blood count, liver and renal functions, and pregnancy testing has to be done before giving to the before starting the methotrexate therapy. And cyclosporine provides a rapid control for severe unstable conditions and erythrodermic or pustular psoriasis, but is time limited by nephrotoxicity and hypertension, where the patient before starting the cyclosporine, these things has to be taken care of, or the nephrotoxicity or the hypertension, these things has to be considered. And other systemic therapy like acitretin can be considered. Oral alternatives include like targeted small molecules such as apremilast, APDE4 inhibitor, and along with that like other JAK inhibitors such as like deucravacitinib and tofacitinib. Sorry. Okay, other treatment options include systemic therapy, acitretin. Oral alternatives include like targeted small molecules such as apremilast, that is PDE4 inhibitors, and JAK inhibitors such as deucravacitinib and tofacitinib can be used. And other biologics, as I told, like other treatment options includes like biologics that are highly effective for moderate to severe cases of psoriasis. In 23, the British Academy of Dermatology updated recommends that includes like TNF alpha inhibitors, interleukin 17 inhibitor, interleukin 12 by 23 inhibitors, and interleukin 23 inhibitors. And here the interleukin 23 inhibitors are the first line biologics which are used. And interleukin 17 and 23 inhibitors offers rapid, high level skin clearance and durable responses, whereas ustekinumab, that is interleukin 12 by 23, and TNF inhibitors remains preferred in patients with psoriatic arthritis or specific comorbidities. Coming to the TNF alpha inhibitors, there are so many drugs which are there, like as I can say, like adalimumab can be present, etanercept can be used, infliximab, certolizumab, and interleukin 12-23 inhibitors, which includes like ustekinumab, and interleukin 17 inhibitors like secukinumab, ixekizumab, and brodalumab, and interleukin 23 inhibitors like guselkumab, risankizumab, and tildrakizumab can be used. And coming to the summary of the today's patients with respect to history, a 45-year-old patient presented with well-defined erythematous plaque with silvery white scales, with extensor surfaces, with positive Grattage test and certain nail changes which were suggestive of chronic plaque psoriasis. Thank you.